Hello and welcome to session 3 of the IJR press workshop. So today we'll be involved in critique of a sample manuscript where all of you have already been divided into groups. So we'll have the team leaders convey your thoughts while the faculty tell you how to go about it. So we begin with the introduction, which will be taken by Dr. Vinod Ravindran.
So how do you want to do it, Latika? Just for the benefit of everybody.
So
Good evening.
we have Dr. Ritasman here. He is the group volunteer for the introduction section. So probably you could share your screen, and I think Ritasman has already shared sample corrections.
May I interrupt?
Yes.
Hi, this is Ashish here. So what we decided for our group, how we were going to do it was this. The group leader discusses in 3 to 5 minutes what his group's take is on that. Then he invites the other group members to speak for a minute if they have any additional comments. And then I would take it up as the group moderator or lead or faculty advisor to have any additional comments on that. So that is the plan that we are going to follow. If that is agreeable to all, we may follow a universal, similarly a similar plan. Otherwise, I'm happy to do it as we plan.
Yeah, I think that's a reasonable plan. That maybe they need more than 5 minutes. So okay, so fine. So who's the are you going to show the corrected version or something where you noted down your comments and then you talk about it?
So in our group, we have prepared a PowerPoint presentation by the group leader who has about 9 slides to present. And I believe if they take more than 5 minutes, then we really won't need to actually add much. I'll be happy they take more than 5-10 minutes so that they have discussed everything and I wouldn't have much to add on that.
Yeah, thank you. Latika, where is my group leader? Is he there somewhere?
Latika, you need to unmute your mic before you speak.
So why don't we start with results? Because I think the group leader, he's not able to unmute for some technical reason. So
yeah, okay.
Let's begin with results. Anyhow, the methods.
I would prefer if we begin with methods. Either we follow the IMRD sequence, introduction, methods, results, discussion, or we follow the methods, results, intro discussion. An MRID or IMRD, one of those two.
Right. I am Dr. Ritoshman. I am here.
Great. Thank you very much. Let's start from the head. Okay, crack on. Hello.
Dr.
Hello.
Ritoshman, you can share your screen so that we can see whatever you had corrected.
Okay. So you just sort of give us whatever the views were of your group. Okay. Right, yes.
Before that, Dr. Ravindran, would you like to introduce the paper and just give an overview of it to everyone?
Yeah, as the title speaks for itself, So this is, I hope you all agree, is a landmark paper, first of its kind in the world, written by, authored or co-authored by one of the faculty members here. So
The video audible?
Yeah, you are very much
visible.
audible.
It is
okay.
It is visible.
You are visible, and yes, you are audible. Okay, so now this was eventually published in Clinical Rheumatology, but when we started to do this workshop, the idea of a dummy paper came about, And because this is all started with the IJR's initiative, we chose this paper because it's easier to, get criticized and brutalized as the faculty with my own paper. So it is by choice. Molly Thaba, she's an additional professor of medicine at JIPMER. She did, a lot of work to produce a distorted version. The objective of this particular, session is to be able to look at all the segments of a manuscript from a critical standpoint of, I would say, as an editor, really, where you'll be making crucial decisions about the quality and the validity of content as you, perceive it, so that you allow this to go forward or you stop it with some of the valid questions you may have. Okay. So with that short introduction, I would ask, is it Ritasman?
Yes, sir.
Yeah. Okay, Ritasman, please go ahead.
Actually, this I have come through the introduction part and I have taken the views of other the group members also. And after all this, I have come to some points which I found that okay, just 1 minute. That is in the introduction part. The initially that this first is the it is lengthy to some extent. To some, that is the first introduction part about the this name chikungunya derives from a word in the language, and all this what is it is needed or not in this context, because for first 2 paragraph it is given the description of the virus disease and the virus and vector transmission. But the title of the article was DMARD therapy in chikungunya arthritis. So it is more chikungunya arthritis that should be more focused. But in the first para, second para, even in the third para also, I found that it is only virus, how the virus transmission is going on, and what is the virus vector, and all these are it is more it is detailedly explained rather than the more about the chikungunya arthritis. Regarding chikungunya arthritis, it starts from the 6th para. This para onwards it is starting. Before that, after the bite of the infected mosquito, onset of illness occurs. I think these all are not needed in this context, because we are diverting from the main hypothesis of the article. And when I search for what is the hypothesis of the article, actual question of the article I didn't find. What is what the hypothesis they want to know. And another I found that they have one study written that is here. Hello.
Yeah.
Hello.
Mm-hmm.
And here I found that one what is it 2008 a study was published in India, but I think it should be mentioned the who study it is, because it is better to mention the study at all by the author of the study. And there is mentioned that in this study 48% responded to methotrexate and SCQ after 16-week therapy, but the next very next portion it is not mentioned that yet such have never been done in the world. But I don't know whether you can write like comment that never been done in the world, because we have not we have to do a lot of adequate research before telling that no study has done throughout the world regarding chronic chikungunya arthritis with DMARDs. Because I personally remember that during one of my presentation, I present two articles where the DMARDs were used in the chronic chikungunya arthritis. So in this comment, this section, I was feeling that this line should be changed, or that should be written like limited numbers. And then the main is the objectives. They are written that aims and objectives of this study. It should be, I think, written like primary objective and secondary objective rather than these three objective. And they have written in the first to determine the characteristic of chikungunya arthritis which predicts response to therapy. I think it is not the primary objective, because the title of the study is to evaluate the demand response in the chronic CA. So to evaluate the efficacy of the DMARDS combination in chronic persistent CA, it should be come first as primary objective. And then we can tell that the other objectives to study the response, but which are the responses we want to see, rather than detailing the virus and vector transmission and disease outbreak. This part should be elaborate more, because we want to see which response, and at 3, 6, and 12 months follow up by with which demands, and whether we use any placebo therapy or not. I'm not telling that details should be written here, but to continue the flow of the article, that it should be touched, like the primary objective is to evaluate the efficacy of DMARD combination in chronic CA, and the other secondary objectives are to respond the therapy in the form of this, like, and compared to the placebo therapy, and which are DMARDs are used. That is also not mentioned here. Okay. So I make some questions like that. There are repeated discussions about virus vector transmission mode of the disease.
Hang on, can you show us that you know, where you have put the questions, you know, 7 or 8 questions? Can you bring that up somewhere?
Yeah. Yes, sir.
Yeah.
Is it visible?
You can share your screen, Ritasman, then we can see it.
I have shared already.
No,
maybe
we can
Dr.
see
Ravindran can stop
meeting.
sharing.
Just a minute.
Yeah, this one, fantastic.
Actually, these questions which I made, there are repeated discussion about the virus regarding the information of the virus vector and transmission mode of the disease. I think which are not needed in this context of the article. To detail discussion.
Okay, so sorry to interrupt. So I think these points you have already covered in you know, just now. So there are no new points here, isn't it?
No. This is all the points which I come, and actually I make a correction of I make a scoring of a rubric system. That I want to share once more.
Please. Okay. So anyway, while he's bringing, I think this is a very, very good effort from this group, and I think, you know, all the points have been captured. Some of the things which you said, you know, where you yourself have used the word, you know, probably should not be there. You have to take a final call. Okay. So if you are a reviewer or an editor, you have to take the final call saying that, you know, this is definitely not needed. Okay. So if you feel that, you know, historical details are perhaps not required, when you put the comments, you have to commit to yourself whether it is definitely required or not. Okay. So, you know, beyond you, there is no scope for any confusion. How many of you really feel that, you know, the study should be mentioned by the authors or the first author's name at all? I would say that, you know, it could be either of this is correct. Okay, you can mention that, you know, a recent study or a study published in 2008 or a study published in 2018 from, you know, the Central India. Okay. Or you can say previously study by Ravindran et al. Or previously study by Gupta et al. Have found. So both the styles are completely okay. for referencing, you know that, we are actually following the modified Vancouver system. So we are not following the AMA system. So what is used in thesis is not at all, into play in this one. Some of the, sorry. Yeah. Now let's have a look at this. Yes. Go on.
Yes, sir. This is the analytic 4-level rubric for introduction that I try to scoring this. That is actually there are 6 points. Grades are 4. First was introduction to topic may include clinical aspects and prevalence. That I prefer that overview is present, but what is the clinical aspects and prevalence? It should be more widely expressed.
Yeah.
And
hang on. Sorry. So for the paucity of time, how many minutes we got, Latika, for this one? Remaining.
Since we have 5 items and an hour and a half, so that's 90 minutes.
Yeah. So we got, I think so we have, no, how many we got remaining in this one? Because I just wanted to check.
5 more minutes should be good.
5 minutes, okay. So Ritasman, we need, okay, hang on. So yeah, this was circulated to everybody. Okay, so sorry to budge in, but this is a good effort again from Ritasman and his team, that you can have a system something like this, from, at the beginner's level, I would say. But what is important is when you read the introduction, as we talked in the lecture we had in the first session, that whether or not a descriptive funneling has been used, okay, the background or the context have been set, the controversies or lacunae in our knowledge has been identified, and that is linking into whether or not there is a clear statement of how those gap in the knowledge, lacunae or controversies where would be resolved is there, linking to primary and secondary objectives of the study, or if there is a hypothesis, statement of hypothesis, and it will nicely lead on to the methods where a lot of other things, you would be asking as a reviewer or reader would come in. You can have a system, if you are just sort of, if you are critically actually reviewing a manuscript to give it some sort of marks. But this system is not very useful when you are actually reading this as a reviewer or as an editor. Even as a lay reader also, this system, this type of objective system is not a good approach, because what you want to look at, what is the sense coming out of this manuscript? When you are reading the introduction, are the authors satisfying you in terms of your primary question of them writing the introduction part, that why at all they set on to do this particular study? Okay. Any questions from any other groups or any other comments?
Looks like we have none.
No questions. So it's all very, very clear. And everybody had attended the, and these videos are there on the YouTube now. You can go through it, do's and don'ts of writing the introduction part, some common pitfalls, and then we talked about, how to keep it crisp. And so I got a couple of questions, just to, so the authors have said, and I agree with you, that they should have not said, it's this type of study has never been done, or this is the first study of its kind in India or in the world. So this type of claims and assertions, if at all you are making, has to be written in a slightly different way. But even with the best of searches you have run, just I would not advise you using these type of words at all, because remember, our job is to get past that barrier of from submission to acceptance of our manuscript and be published. So so if we come across very dogmatic, assertive, making claims, tall claims, then it is actually a put off for your reviewers and the editors. So the language has to be, you can be very scientific, academic, but still sort of your language has to be very rounded off. Okay. So I would like to thank Ritasman and his team. I think they've done a brilliant job. Thank you very much.
Right, thank you, Dr. Ravindran. Now we'll move on to results. Dr. Rao and Rudra will be talking about their corrections or their suggestions for the methods, followed by Dr. Durga, who will go over it and brief you on it further. Over to Rudra, who can share his screen, and Dr. Anand Rao.
I think let Rudra do the talking, Latika. He's done a good job. Yeah, Rudra, you'll do the talking?
Yes, I think he is unmuting himself.
Okay.
Yeah. So right at the onset, since this is a clinical trial, there is no mention at all in this entire method section of an institutional ethics review and the approval letter number, which should be mentioned. Also, being a clinical trial, I feel a data safety monitoring board that must have been constituted should be mentioned in the methods, and whether it was a blinded trial, whether it was an open label trial, that should be very clearly mentioned. So going into the specifics, on the first sentence itself, there's a repetition. The first sentence says it's a prospective study, and the second statement again says it's a prospective randomized study. So it can be clubbed into one sentence and probably in a single sentence saying whether there's a control group or not, whether there's a blinding or not. So it can be all condensed into one statement. So something like it's a prospective randomized control open label study, or a prospective randomized control double blind or a single blind study. Following that, I think the inclusion criteria have been mentioned, but what have not been mentioned here are the set of exclusion criteria, which I feel are more important. When a clinical trial is being run, patients who are going to be excluded there's generally a set of exclusion criteria for patients who have transaminitis or some sort of baseline abnormality that precludes their inclusion into a clinical trial. So the exclusion criteria need to be mentioned very clearly, more clearly than this. Next, the definitions of virus detection for chikungunya, that they have been enlisted in bullet points here. I would rather have them in a separate section under the heading of definitions, where we define everything pertaining to the trial that we want to have definitions for. So I would make this a separate subsection in the methodology, maybe at the end, perhaps. So coming to this next sentence, it is interesting to note that there were more than 500 patients. So I would avoid such adjectives like interesting to note. If at all I have to make that observation, I would put that in the discussion rather than the method section. And again, greater than 500, it's a very non-specific thing. Was it 501 patients? Was it 50,000 patients? We don't really get any information how many patients actually were there. So a specific number instead of something like greater than 500 would be better. So next, coming to the next issue, I felt again here using an adjective, unfortunately, during the study period, I would much rather just state how many patients were screened, and the reason for screening a lower number of patients as compared to the number of cases. That is important. I mean, a flow chart here I think most journals now mandate for any clinical trial a flowchart in which the number of patients screened, the number of patients included, and the reasons for exclusion need to be very clearly mentioned in a flowchart form. So that would be a better way to probably represent this, the screening. So the next issue I had was there are multiple changes to the tense. So right up until this point, everything had been written in past tense. So for example, those who had a history of arthritis and had active disease were already on HCQ therapy, and suddenly it goes on to a future tense. They will be randomized to either HCQ monotherapy or combination DMARDs. So assuming that this is being sent for publication, this trial has already been conducted. It should be in the past tense that they were randomized to either of these groups. Okay, so the next issue I felt here was so again multiple changes in tense from past and future tense that is present throughout this method section. Again, the statement that although all patients had x-rays and feet taken, none of them had any bony erosions, which we presumed was a good sign. So this is again a statement that is better fitted to the discussion than it is to the method section, I feel, because it's an opinion of the author and it's not really related to the methodology of the paper. Again, this statement of whether erosive okay. I'm sorry. Yeah, so this is more like a presumption of the author. It should not be in the methods. Here the outcome measures that have been mentioned, DAS28, ESR or CRP. Again, I would prefer exact numbers of how many patients, for how many patients DAS28, ESR, CRP were available, and for how many patients it was not available and a CDI was done. The authors have just mentioned that it was done in this manner, but not the exact numbers. Again, a flowchart would be a better way to represent this. Again, this statement that a few patients also had their quality of life assessment done, this is a very vague statement to put in the methods. Even if you want to mention that a few patients, I would rather know how those few patients were selected, whether they were sequentially selected from the first patients who presented, or whether it was a random sampling done from the patient population, and the exact number who had their quality of life assessments done. I mean, that would have a direct bearing on the results. And okay, so a lot of tense changes again in this entire section. So from past tense to future tense, there's a frequent change in the tense which should not occur. It should be all in one tense. So again, as you see, both groups of patients will also receive oral or low dose prednisolone. Going again to future tense, that does not make much sense since this trial has already been conducted. Okay, so the outcome measures and when they have been recorded have not exactly been mentioned. So the time points at which these measurements have been done, ESR, liver function tests, and CBC, rather than at regular intervals, I would much rather have something like a 2, 4, 6 weeks or a definite time interval when these investigations were done. Now in the statistical analysis, I had a few issues. Number one is the computer software. I think the specific software needs to be mentioned. And if it is something like Stata or R, where like the code can be reproduced, then maybe that can be added in the supplementary section where a reproducible code can be put in the supplementary data. Again, here the statistical hypothesis testing, they have mentioned the student's t-test for the continuous variables, which is actually a test for parametric data, and for the categorical variables for proportions, they've mentioned Fisher's exact test, which is a test for non-parametric data. So rather, it would be better to give a generic statement. Key parametric, the distribution of data was analyzed, and we used a t-test for parametric and a Wilcoxon sign rank test for non-parametric data. And similarly for categorical variables, for parametric, a chi-square, and a non-parametric, a Fisher's exact test were used. So something like that would be more prudent, I feel. The sample size collection, maybe in a separate section, we could add the sample size collection. So I think those are my issues with this method section. Thank you.
Thank you, Rudraarpan. It was a wonderful dissection of the method section. There are some more inputs which came in from Kasturi and Srijita. I will just add them along with mine. I'll just be sharing the screen. Just a minute. Is my screen visible?
Yeah, it is.
No, 1 minute. Let me just see. Okay. So I've just clubbed all those suggestions which came in from my team members. Srijita also had wonderful suggestions to give. The same thing that Dr. Ravindran has made it, has done a hard work creating difficult method section which anybody can reject. Thank you, sir. So it has too many unnecessary words and repetitions. And there is, Srijita had this contention that there is no clearly stated hypothesis, no mention about ethical clearance, which Rudraarpan did mention. Inclusion criteria are vague, no mention of exclusion criteria. And though they say it's a prospective study, serology results were retrieved, indicate that there is some retrospective component to the same. Method of randomization was not mentioned. Some results and discussions were results and discussion points are included in the methods, which Rudraarpan already made. The tense was very confusing. So shifting from past to present, present to future, and the assessments at follow-ups, what were the assessments which are done was not clearly mentioned. And according to me, apart from these nice inputs from Srijita, it is a disjointed method section. They keep jumping from one place to the another with a lot of randomness and a lot of vague statements which were made during the methods section. Kasturi had this, that the abbreviations were used without any elaboration prior to that. And these were our, I've added Rudraarpan's statements too. These were our critique about the method section here. Thank you. Latika, are you there?
Thank you, Dr. Rao and Rudra. Rudra, that was brutal but brilliant. And indeed, subheadings are required. There has to be clarity of numbers, and repetition should be avoided, and tense has to be taken care of. Now, Dr. Durga will brief you further on his inputs.
Good evening, everybody. Before I start, I would just like to go back to Rudra and Dr. Rao and just ask, was there anything good that you could find in the methods? We have all criticized the lacunae, but were there any good points, really good points that you could identify there?
For people being initiated, we only picked up we actually took the critique to the basic word level and we looked at the critical points. I think we didn't pick up the good points. Durga, you should let us know.
Okay, I'll just start with the good points. So for a change, I'm just sharing my screen. If we see, this is one of the really good points about this. They have very categorically described how sample size was reached using what assumptions and what dropout rate. Of course, they have still missed something. They have missed the estimates of difference between the groups, but still many people even do not do this. So that in itself is a good thing. And most of the lacuna, I think you have all pointed out very nicely. I would just like to add a couple of points. One is Rudra had mentioned about the outcomes, that various different outcomes were used, and regarding in how many patients each of these outcomes was used should be described. But overall, such heterogeneous outcomes should be avoided. One should stick to one or two types of outcomes and uniformly assess them across the study, because obviously if you are later going to compare in a patient whose disease activity score was say measured by DAS28 or by the CDAI, you cannot really compare the two. A percentage change in the DAS28 is not the same as a percentage change in the CDAI, of course. And they may not even categorize patients at the same level of disease activity of low or moderate or high disease activity. So it's best to avoid such heterogeneous outcomes. And the other important criticism was that if it was a clinical trial today, it would require trial registration before the trial was started. Previously, trial registration could have been done even after the trial was completed, but since the beginning of 2019, it is not possible to register trials after they have started. So you must, at this moment, if you are planning to conduct a clinical trial in the future, you must register it either with the Clinical Trials Registry of India or with clinicaltrials.gov before you start recruiting the first patient. That is an important thing. I think Rudra might have covered it, but I thought I'll just emphasize on that. Otherwise, most of the points that Rudra has brought out and Dr. Rao has brought out are fantastic, and you have nicely criticized the method section. In case there is anything else that I'm missing, if Dr. Vinod could give any inputs, I really couldn't find anything more to criticize about the method section.
So I have some comments in the meantime. Rudra was very brutal about the tense in the paper and the writing. So generally, the most common problem that arises with the tense, and it occurs usually in the method section itself, and is always because you write first a proposal. When you write a proposal, you write it in the future tense, and you describe what you will be doing. And when you finally write the paper, you just copy and paste it from there, and you do not write it again, or you would forget to change the tense. So that's the usual problem that happens, and one which definitely everybody in this workshop should be careful about in the future, so that you don't make that mistake. When we do that copying and pasting, this is the usual problem that happens, and it's very irritating for a reviewer.
Yes, Dr. Goel, I very much agree with that point. That is a common mistake that inexperienced authors would often make. And one must not fall prey to this fallacy of just copying the methods section from the protocol. More so with a clinical trial, you definitely have had a protocol before, so it's all the more point to be kept in mind when it's a clinical trial. Definitely ensure that the methods is written in a consistent past tense, because you've already done it by the time you have written. You're writing up the study is already over. Whereas at the time of the protocol generation, you are planning to do it. So you would write that I will do this, I will do that. Whereas in the manuscript, you would write, I have done this, I have done that, etc.
Yeah. Durga?
Yes, sir.
Yeah, okay, thank you. I think this was exactly, what was intended by honing your skills on this dummy manuscript. So I think this group also has done wonderfully well. What I want to say is that you don't have to be subject expert, to critically appraise a paper's writing aspect, okay, or asking the question as to whether or not sufficient information is there in the method section. So if the beginners in this field want to practice sort of how to pick up the problems, in a given manuscript, it is best to actually use manuscripts which are not related to your specialty. Okay. This dummy paper, and of course also the dummy paper which has been created by Durga, and we used to use one by Dr. Shankar earlier. The workshops are not for rheumatologists. So we have, junior faculty and medical postgraduate students from all the specialties. And the same paper has been used. Okay, all the 3 papers I mentioned, they are all, related to rheumatology. So the important thing is that to critically appraise a paper, you don't have to be a subject expert. Subject expertise is required because, then of course, you are required to know some of the specific stuff. Basic knowledge of statistics is important, but again, you don't have to be, really a major expert in statistics. This is one thing, and I think I noted it down. And I think that's it. That's the only thing I would add in. If I remember something, and yes, I would like to really. I feel doubly happy every time this is done. that you people are wonderful. People are not the editors, or you were not the editors of this manuscript. Okay. Thank you very much.
Thank you, sir. And any questions are welcome. Otherwise, we can move on to the next section.
I have a question.
Yes, please.
In statistical analysis, it is written that data management and part protocol analysis were carried out by the statistician. As per in this part, why did separately mention part protocol analysis? Because then they're coming on the missing data or intention to treat analysis, but they are not anywhere mentioned about all these things.
No, that's a good thing actually. They've mentioned per protocol analysis. They have at least specified the reason for the choice they have made of per protocol rather than intention to treat. They probably should have explained that, but it's fine enough to have said that.
Should there is mention of the number of missing data then, if there is per protocol analysis, or how many dropout, how many died, all this?
The results, once you have the flow chart for describing study selection, that is where it would be described. So it's not necessary to mention that here, although a per protocol analysis being mentioned here, it makes it likely that there is a lot of missing data, as you have said, that follow-up was probably incomplete. So just unrelated to this, when do you think a per protocol analysis is a good strategy rather than an intention to treat analysis? Is there any particular situation of a clinical trial where a per protocol is preferred rather than an intention to treat? Just a general question to everybody.
When the dropout rate is high, perhaps.
Yes, that is generally when per protocol is used, but then again, per protocol has a potential to give you a difference between groups when in real life such a difference may not exist. Intention to treat is a much more, in a superiority trial, intention to treat is a much more conservative analysis. But is there any particular kind of trial, commonly used trial, in which a per protocol analysis is preferred? Or would you all like to find that out? Just go back and read today. We can discuss in the next class.
Okay.
Durga, I had this question. So if you have, when you're using the tense, so it would be advisable to use a past tense when you're writing a manuscript. Is that so?
Yes, because it's already done.
Okay, so everything is in past tense, the same tense.
Yes.
Okay. And if you can just elaborate on this per protocol analysis versus intention to treat, please.
Yes, intention to treat analysis, basically, if you're doing a randomized controlled trial, you're randomizing into 2 different groups. Now, intention to treat analyzes only the intention to randomize to a particular group. You have intervention A, you have intervention B. The patient may have shifted from intervention A to B or from B to A, or have discontinued. But you have the outcomes at the end of the follow-up period. You just analyze them based on what was the intention to treat, what was the group that they were randomized to. So here, essentially, if it's a superiority design, you would get conservative estimates, in the sense that unless there is a really good effect size, you're not going to see a difference. So it is more conservative in the sense that you are unlikely to get false positive differences. You are unlikely to get false sense of superiority of a drug as compared to placebo. Unless the difference is really good, you're unlikely to get a positive result on an intention to treat. Whereas per protocol would take into account the protocol deviations. So finally, those who were on treatment A versus finally those who are on treatment B. So here it is more real life. And here you're likely to get a difference between groups, even when it may not exist. So your chances of a false positive result are much more. And this situation is actually contrary to what you would want in a non-inferiority trial. In a non-inferiority trial, you are looking for evidence that the two treatments are not dissimilar. There, it is a per protocol analysis that is preferred rather than an intention to treat. In a non-inferiority trial, a per protocol analysis is more conservative than an intention to treat, which actually may show you a difference when such a difference doesn't exist. But generally for superiority trials, it is an intention to treat that is preferred.
Sure. Thank you. Thank you.
Thank you.
Thank you, Dr. Durga. We'll now move on to results. Over to Dr. Goel and the team leader, Abhishek.
Yeah, I think Abhishek can start off and then we can take it up.
Major Abhishek, can you share your screen?
I'm trying that. Am I audible?
Yes, you are. Can you share your screen, the green button at the bottom?
Yes, I'm trying that. I think there's some problem with the system preferences.
Try now, Abhishek.
Right, I can show your slides, meanwhile, if that's convenient.
Just 1 second. I will have to quit for some time, then I'll have to come back again. So what I'll do, I'll send the slides again to your inbox. Then you can share the slides.
I can share your slides, Abhishek.
Yeah, I think the slides has been updated, so I'll share you again.
Right.
Share with you again, okay.
You can share it with everyone in the chat box. In this Zoom itself, you can share it with everyone in the chat box.
Meanwhile, I will read out the comments. Dr. Goel, would you like to read the comments?
Meanwhile, shall I start?
Yes, start, please.
So, here as a team leader of group 3, I'm supposed to discuss the analysis of the results aspect. So I have used that analytic rubric format for discussion. which was provided by the facilitator. So this analytic rubric has helped me a lot in presenting this analysis, because when I was proceeding through by line into the article and pointing out the mistakes, I was jumping from one sort of mistake to another and coming back to the same sort of mistakes again. So that was the issue coming on, and this has actually helped me in conceptualizing, dividing those mistakes into a different conceptual mistakes, and so that it gives a better way of viewing on these mistakes and getting a concept of writing the results in a better way. So I will come to this analytic rubric. So it has broadly divided these results into three broad groups, that's text, tables, titles, and figures and legends. And there it has been further been subdivided into 9 groups. For each group, there is the possible scores are 1 to 4 as per the appropriateness of the description. So the maximum marks can be 36. Can I have the next slide, please? So in the first, we will analyze the text part. So the first concept which has to be analyzed here was the strategy. So here we have scored it 1 because it was a very poorly organized. I'll request that everybody should have one copy of the article in their mobile or a hard copy in their hand so that they can refer back to them, because I'm not presenting those particular mistakes in these slides. So if you see the organization of the results, the information regarding aim1 is completely missing. The aim1, which was described in the introduction part, was to determine the characteristic of chikungunya arthritis, which predicts the response to therapy. There is no information about it at all. And if you come to the aim3, the timeline which has follow-up timeline which has been mentioned in aim3 is 3, 6, and 12 months. And this is entirely incongruous, because in the tables they have described the follow-up data of 0, 4, and 24 weeks, and in the figure it is 8, 16, and 24 weeks. And while describing the data, there's no uniform nomenclature has been used for the two groups. At some places it has been used as the monotherapy group and versus combination group, and some places it has been used as group 1 and group 2, which becomes quite confusing at times. The data in the table has been repeated in the text. So everything which is there in the table is almost everything is present in the text also. And coming to the first para, the first para which contains some aspects related to the X-ray findings, rheumatoid arthritis in relation to chikungunya arthritis, and rheumatoid factor and enzyme antibodies, which are irrelevant as per the study protocol or the aims of the study. So this could have been a post hoc analysis and could have been possibly discussed at the end of the results rather than in the first para itself. In the last line of the para 1, that is that should be a part of the discussion, not in the part of the results, and it was very awkward to find this part in the results part itself. And in the last paragraph of the results, they have discussed the withdrawal from the therapy because of the adverse effect, and this will make a part of the initial part of the results itself, when that flowchart is supposed to be given a flowchart about randomization and withdrawal of the study those parts. Now coming to the next group concept on which this results parts have been analyzed was whether it meets the goals of the study or not. So as we discussed earlier, that objective 1 was entirely missed, and it meets only partially the objective 3, and that was also incongruous. So it has been scored 2 out of 4. Can I have the next slide, please? And coming to the inclusion of data, so we have scored 2 out of 4 because there was the description of stats were very poor. Like at certain places, the numbers have been written, but no percentages. At certain places, only percentages are written, but no numbers has been given. And there are similar mistakes at many places. And the description of stats are absent or inaccurate at many places. I would like to give an example of that. In the first paragraph itself, it is said that total 72 patients met the inclusion criteria. But in the next line, it says that there were 65 females in group 1 and 69 patients in group 2. So this was factually wrong. And at many places, the statistical significance has been expressed as a clinical significance, which is obvious in the line which says that patients who received combination therapy had quite highly significant improvement in disease activity. So this, I think this is not the correct way to interpret the findings in the results section itself. So this is, can I have the previous slide, please? Okay. So, and the figure 1 has been cited in the text, but it is missing from the manuscript. And table 1 is cited in the, table 1 is given, but it is not cited in the text. Next slide, please. And this has been provided to me by Dr. Surabhi and Dr. Kavya. So this is possibly the, this would have been made in the first part of the result section, where it has shown that 500 patients were assessed. These many patients were excluded. 72 patients met the inclusion criteria. They were randomized into 37 and 35 in two groups, in combination DMARD 37 and in the monotherapy group 35. 3 discontinued in combination DMARD group, and 7 discontinued in the monotherapy group, and the total 34 in the combination group and 28 in combination group. They completed the study. So this could have been a better presentation in the of the results. Can I have the next slide, please? Now coming to the analysis of the tables. Now, when you see the titles, if you see the title of the table 1, so it vaguely writes that demographics and disease related variables in the groups. So we came out with possibly a better title, that comparative demographics and baseline disease characteristics in study patients. And similarly in table 2, the key parameters over time in both groups. This is also very short and little vague. It doesn't, it can be little more descriptive. And so we came out with this heading title of this table, the disease activity parameters at different intervals during 6 months of follow-up.
Abhishek, I'm feeling miserable to stop you, but can we do it a little more quickly? You can give your broad comments rather than the specific things, otherwise we'll be missing out.
Okay. So coming to the layout form, there in the table 1, there was no hierarchy as such, and the footnotes were missing, and some of the data would have been better missed out, like erosions and anti-CCP antibodies. And similarly in the table 2, the footnotes are missing. Next slide, please. Next slide, please. And yeah, previous one. Yeah, and coming to the contents of the tables, it has, the data presentation is poor. Like if you see the female parts, whether it is percentage or number that is missing, the p-value has been inappropriately described. And mean, in my view, it should be written mean comma standard deviation rather than mean plus minus standard deviation. And one mistake I could make out that in table 2, that SJC, TJC, and ESR has been described in the form of median and range. and dash 28 in the mean and standard deviation. So there were little incongruity in this because the dash 28 is derived from these three parameters only. So if if the dash 28 was normally distributed and could be described in mean and standard deviation, possibly these three could have been also described in the mean and standard deviation. And coming to the next, the reasons of the figure that one of the abbreviation is missing, that is ESR. And next one. And in the graphings, there is no proper labeling of the X and Y axis. And although the line diagram, the values could have been given at the follow-up points that could have made a better sense of the figure. And contents of the table 2 and the figure 2 contains almost the same thing of the disease activity. So this could have been avoided. That's it from my side. So out of the total 32, score given was 12.
I think that's a brutal and brilliant job by Abhishek, and I must congratulate you. I'm sure that Dr. Ravindran should have some of you at least, especially Abhishek, as editors and reviewers on the journal, and they would do a really good job at improving the quality of articles. Yes, I have comments, that's fine. I would be welcoming other people's comments if there are any. Dr. Durga, Dr. Ravindran, if you have any comments, please, please do share. I did find words like about and quite highly significant. These are not like, I mean, you don't see those kind of words in the results section. Highly significant, quite high. Definitely these words should be avoided in writing. This is where age has been described as 54.05, multiple places which have no relevance actually in writing the results. Yes, any other comments? Yeah. I think if there are no comments, we should move on to the next section.
Yes, Major Abhishek, that was very detailed and brilliant. Thank you so much. And now we move on to discussion, which will be covered by Naveen and Chengappa.
Yeah. Can I share my screen, Dr. Latika?
Sure.
Hi, everyone. We are probably at the most important part of the manuscript. Since we have done all these things, the methods, the results, it is relatively easier. It's not easy still. It's relatively easier to write, but discussion needs a bit of creativity. And I think we should be a little sensible and humble about our results. So going forward, I'll just revise on what Professor Vikas Agarwal had told us in the last class about writing a discussion. So we have to see what does the study mean, and we have to communicate what the study means to others. Now, others, we are not talking to lay people. We are specifically targeting certain group of audience. So we have to be clear about whom we are going to address this study to. So it is, first of all, it has to, we should be able to communicate what this study means to us as authors, then to the readers, and to the overall scientific community in terms of the future perspectives. So what we have to do in a discussion is we have to base all the discussion on the based on the findings of the particular study. And then we highlight the important aspects of the study. Then we try to bring out the new aspects that was not described or not correctly described across other studies, and then finally conclude. It's as simple as these four things. But to do that, what we have to do is we have to imagine a discussion, writing a discussion like starting off this workshop. So first we introduced each other's topic. Then we put out the results, like if all of you just pointed out that this was the error, this was the error, this was the error, and these constitute our results. Finally, we discuss why these are the errors, right? So this is the important part, that why is this result important for the study or for the subject as whole. So now in discussion, we don't go back to introduction. We don't talk about who is again presenting this and why was this done. But we keep cycling between the results and discussion. So based on your result, we discuss. Based on the discussion, we can go on to the next part of the result. So keeping this in mind, so what we do is, first of all, we have to give statement of principal findings in the discussion. Then we discuss about the strength and weakness in relation to other studies. Then we discuss what is the meaning of my study. Finally, the strength and weakness of this study. This has to be honest and this has to be rational. It's important that we put out our weakness rather than somebody point out. And if there are a lot of weaknesses that are pointed out by the reviewer, there's a higher chance that your manuscript is going to be rejected. And then finally, just state what are the unanswered questions and what is the avenue for further research based on your study. So opening paragraph should address the goals and hypothesis, how your results have addressed. So give a brief summary of the results, not detailed summary. And then you interpret your results in the context of previous knowledge. So first state the answer that you got and state the relevant result as a summary, and then cite from the articles across the world. Then defend your answers. If you have found something different, try to defend it rationally. But while doing so, make sure that you present both the sides of the explanation. You know, there could be contradictory evidence, there could be evidence that support your study. So you have to discuss both and then come to a conclusion, stating why you have come to a conclusion. Finally, discuss and evaluate the conflicting explanations of the results. So always address the audience. Don't forget whom you're addressing to, and discuss the unexplained and unexpected data. You have to highlight if you have found some unexpected data, but don't go in length discussing on that. Again, discuss the limitation and strength of the study. Finally, come to a recommendation or a proposal for a further study. You should first, while writing a discussion, we have to remember that this is not a review article. We don't have to quote all the 100 articles talking about this particular subject or particular result. And we have to be brief and not elaborate while doing a discussion. Do not waste time restating all the results again. Some might really be irrelevant. Do not introduce new results. This is very important. Sometimes what happens is, you know, while writing the discussion, you would have thought of some other way of analyzing your data. And instead of mentioning it in the results first, you will directly put it out in the discussion that when we did maybe a logistic regression, we found this and that. So that should not come as a surprise to the reader. It should have been first discussed in the results and only then should be discussed here in the discussion part. And do not overinterpret the results. Most of the times, if your study is underpowered to tell something, don't say that it is definitely the case. You know, we have to be a little conservative, and we have to once we write the discussion, we have to reread it and remove all the unnecessary words, some adjectives, adverbs, whatever is unnecessary.
Yeah. Chengappa, sorry to bother you.
Yes.
Sorry to interrupt. Yeah, it's Vinod. See, Dr. Vikas had given a very detailed lecture. Can we just look at the manuscript and sort of, yeah. Okay, let's discuss the manuscript, please.
Yeah.
Okay. Yeah, we haven't got time. We have to finish this off, please.
Sure,
Thank you.
Yeah, Dr. Naveen can take ahead with the manuscript and its.
Yeah, just the manuscript, and please discuss, whatever you have found. Okay. Thank you.
Good evening, everyone. I'll be discussing the discussion part. What I found is the results are not summarized in the first paragraph. Usually the first paragraph summarizes the primary objectives, the results which we have got, Then a lot of results are stated as such in the discussion. Then usual approach is specific to a general approach which is followed in discussion is not seen here. Certain historic details are stated as such here, like 2004 to 2011 chikungunya epidemic alone has affected 1.4 to 6.5. These are not needed even in the introduction part first. So the structured discussion is not seen. And
Naveen,
some boards,
sorry,
like,
are you sharing some screen or something? Yeah. Okay, please. Thank you.
yes, so I'm sharing screen.
Yeah.
Is it viewable, sir?
Yeah. Now it is.
Now you are visible.
Yeah. Now you're right. Yeah. Thank you. Yes.
Okay.
Yes.
The first paragraph doesn't have the summary of the results, as I've stated. A lot of statements are given, which can be given in the introduction part, and specific to general approach is not followed. Conclusively proved the chikungunya arthritis statement. Such statements needn't be stated here, in a little exaggeration. Then the mean age of study patients in the combination group versus the monotherapy stated here, which can be stated in the results because they are not different as such. They needn't be stated in the discussion part. The discussion part, I found a lot of results are as such written here. Rather than that, better will be the interpretation of the results and how is it different from other cohorts would be more meaningful. Here the figure reference 1 is given here, but this figure will be pertaining to the results part rather than the discussion part. They've stated only one limitation here, but few other limitations are discussed in the prior paragraphs, which can be clubbed together. Strengths and limitation can come as a second paragraph together. There are a lot of extra paragraphs which can be brought in briefly. Then here, about future directions and research needs can be included as a pre-final paragraph. In the final paragraph, they have concluded that based on our results, all patients with chikungunya arthritis should receive DMARDs irrespective of duration of illness. But the study group is the patients who had chronic chikungunya arthritis are the ones who are studied. So you cannot apply this results to all the patients with chikungunya arthritis, and to state that all should receive DMARDs irrespective of the duration is not per se part of the study. And we urge the government and authorities to take steps to control mosquito-borne infection illness as a general statement. It is not pertaining to the study. That's all. So the structure of the discussion can be reformatted and it can be a lot more reduced, and words can be reduced as such. And the primary objective, secondary objectives are not discussed clearly in the discussion part. And I have a rubric. Whether the discussion addresses the goals, hypothesis in opening paragraph, no. Interpretation of results in the context of previous knowledge, it is weak. Interpretation does not consider all aspects presented in the introduction or the methods. Whether it addresses the primary audience, it is present, but its implications are not well explained. The secondary audience, per se, it doesn't address. Does it discuss unexplained data? No. Does it discuss limitations of study? Yes, it discusses, but it's not put together in a paragraph. It is placed in 2-3 places differently. The recommendations are present, but it is at times poorly expressed. Patients are chronic chikungunya arthritis patients, not all chikungunya arthritis patients. And closing is present, but it is poorly expressed or weakly expressed. A score of 13 is given out of 30. Thank you.
Thanks, Naveen. Chengappa, your comments?
Yeah, thank you, Naveen. We have got a few more comments from Dr. Supriya and Dr. Sunita. So most of these comments were addressed by Dr. Naveen, but overinflating of results, that has translated to actually exaggerated claims in the conclusion, like, it has to be given to all the patients and things like this. So that has to be avoided. Otherwise, I think I have nothing more to add for this.
Thank you, Chengappa and Naveen, for telling us more about the discussion. Now we'll move to the last section of the manuscript, that is the abstract and keywords. Dr. Suma is with me, and I'll appreciate if all of us can, all of you can join us in this with your inputs, because as Dr. Goel previously told and Dr. Durga went over, the abstract is the most important part of your manuscript, because that is the most read part of your paper, the title, keywords, and the abstract. And it needs to be flawless so that your paper is not rejected in the first go. So Dr. Suma, how do you like me to do it? Do you want me to share my screen and we go editing, you tell me and I edit? Will that work?
Yeah, I think you share your screen.
Okay.
You lead it, yeah.
Right, my cluttered desktop, I will need to first try and find it. So before we get to the abstract, let me just go over this rubric in brief. What does it say really about an abstract? So we need to see if it is precise. So this is the title. Let's go over the abstract first. So it needs to be in good balance. So most of the section, the elements should be equitable in distribution, not really equitable, but appropriately distributed. Like conclusion can be shorter, results needs to be more bulky. Then for the background, limitations and hypotheses, all the key elements should be present and everything needs to be concise. That's the most important bit in an abstract. You need to be concise because you have a pre-specified word limit, which can be as short as 200 words at times. And then for the methods, everything should be present again and concise, and results, it goes the same. And discussion is usually not there, but conclusion should be crisp and should tell you all the important results, putting them in the right perspective. So keeping this in mind, we move on to the abstract, and this is the corrected version, but here we go. So Dr. Suma, you're going to be the mentor for me today, and we look at the introduction first. So the balance, how do you think the balance is for this? Does it look balanced to you?
Actually, see, an abstract is roughly supposed to be around 300 words,
right,
in general. So we need to be careful how we, the proportion in which we allot the different parts of the abstract. So definitely, I mean, an introduction needs to be very, very brief in an abstract. This is probably overweighted to start off with. I mean, a lot of the information in the introduction is probably unnecessary to be in the abstract itself. Like it could be possibly when you start writing the article, at that point you could have this background information. But for the abstract itself, there is a bit too much there in that first paragraph.
So yes, it is 363 words. And I do think that the methods, results, and the introduction, they're roughly the same size, which is not in balance because the introduction could be shorter so that we can put more weight into the results. So keeping that in mind, let's go to the introduction section and read it one by one. It starts with some history, which should not be there in an abstract, I suppose. So maybe this is, and then it talks about chikungunya, how it spreads, which is again not relevant. This is not CT. And it talks about the evidence base. It's trying to create an evidence base for management of chronic chikungunya arthritis. So probably we can chop this off.
Yeah.
This is not required either. And then in a proportion of patients, it may run a chronic persistent phase. Yes, this is very relevant. So we say that we first need to say what is CA. So chikungunya arthritis. And then we define it so that, because we're going to be really miser here with words, we want to reduce them as much as possible because we want to put all the important information there for the editors to find there, so they don't have to go to the manuscript in entirety before they allot it to a reviewer. So chikungunya arthritis might run a chronic, it may run a chronic course. So this is how we reduce words, right? And the treatment for this phase is not very clear. Yes, this is okay. Do you agree, Dr. Suma? This should be fine?
Yeah.
So the objectives of this study were to evaluate.
Was to evaluate.
So we can say we studied or we evaluated. So the words come down again. We evaluated the efficacy of DMR. So this is something we should like to expand. I'm not doing it now for the sake of time, but this you need to expand any sort of abbreviation that you're using. Combination in the persistent CA in a group of patients with chronic CA. So we evaluated the efficacy of DMR combination, but they've studied a combination versus monotherapy. So this is not accurate. You say versus monotherapy. In the persistent CA in a group of patient chronic CA, there's a lot of repetition here, right? So
Yes.
maybe we say in chronic CA.
Yes, in chronic CA.
So we evaluated, and then response to therapy is obvious. So add 3 and 6 months. Right, so we have significantly reduced it now. Are you satisfied, Dr. Suma? Is this okay?
I think this is adequate.
Right, so now we come to the methods.
So methods, again, I think first of all, if you look at the way that paragraph is constructed, there's a lot of confusion. Before we go to the language itself, so it says consecutive patients were screened for eligibility to receive either combination D parts or monotherapy with methotrexate. Subsequently, it says HCQ monotherapy. So there's a lot of,
yes.
I mean, that is hugely, it's a significant error there, which needs correction. So,
and it's also repetition. So I'll chop it off. I'm going to be brutal today. So consecutive 139 patients with persistent CA. Sometimes it's not very nice, but when we're really short of words, I even chop this off. It's obvious we're talking about patients, isn't it? So 139 persistent CA was screened for eligibility. These patients were randomized to receive either combination therapy. So all abbreviations ideally should be expanded when you use them for the first time, or continue, or HCQ monotherapy. This conveys the same meaning, so we don't need to put extra words there. And then both groups received oral prednisolone up to 6 weeks. Up to, again, 2 words.
For 6 weeks.
For 6 weeks. The disease activity was measured. So ideally, it should be a primary outcome and a secondary outcome. That's how we put it. But I don't think it was that way in the manuscript, maybe. So we can stick to this. The disease activity was measured by DAS ESR, comma. So we chop off all these words. IHAC.
But they need to be expanded.
Yes. So we would not do that, but we are reminding you here that you will need to do it in your manuscript. Then follow up. These activities were measured by this, and follow up was for 6 months.
Patients followed up for 6 months.
Yeah.
With recording of the
We can say at baseline and 6 months.
6 months.
Right? Or maybe you did 3 months as well, then you write 3 and 6 months. And adverse events were recorded. Adverse events are important because that shows you're not trying to conceal anything. So I'd keep that. Then going to the results, 74 patients were finally randomized. Okay, you're really tired here. And you will say, okay, finally we are here, but no, we're not going to keep that word. So 74 patients were randomized, 37, 2 combination, okay, 2 can go. And 35 receive is obvious. We've talked about receiving monotherapy. Yep. Mean age. Okay, so now they're saying that the mean age was this and this, and the gender distribution was equal. And then they again go on to say that both the groups were well matched.
Need to come in an abstract, isn't it?
Yes, it could, but if there was a baseline difference, if they're the same, which they ought to be. So you can just put it in 2 words. 74 patients were randomized into matched into comparable groups. That's so many words gone, right? And further, we say at 24 weeks, the combination therapy group showed significant improvement in both disease activity, and then we say mean as standard deviation. So rather than saying that here, we say all values in mean plus standard deviation. So we don't have to write this 3 times. It's pretty obvious. We write it here, and then just the values remain over here. And then we measured the disease activity, disability, and this was significantly less. I would have preferred to put it as a primary and a secondary objective, and then a primary outcome and a secondary outcome, which makes it look really good. So that is something which you may consider for your manuscript if it is based on a similar structure. And then we talk about those who withdrew, which is important if you have the word limit. If not, then you could chop it off. But right now, I think we've really reduced the words, so we can keep that. So now we move on to the conclusion. Again, slightly bulky, I would say. What do you think, Dr. Suma?
I think it can be refined.
Yes, so the present study is the, is the first randomized control study in the world. Yeah, it may be in the world, but then we don't really talk about the universe, so then we're going to chop it off. So to prove the efficacy of DMR therapy, no, just not DMR therapy, we're talking about DMR combination versus monotherapy. So we need to be really specific here because this is undermining the value if we don't talk about the specifics, because there may be another study which talks about some DMR and that will reduce your credibility and whatever you say seems false, while you can be more sure the more specific you are that there is no any other study of this kind, combination versus in chronic persistent CA. Prove the efficacy or prove the superiority. So if it was powered for superiority, then you can say superiority. And based on our results, all patients with chikungunya arthritis, so somewhere we're saying chikungunya arthritis, somewhere we're saying CA, we need to be consistent. They should receive combination DMR. This should not be in small fonts. It should be uppercase. And irrespective of disease duration. So again, this is not something we really mentioned in the results. Something can't come up in the conclusion if it's not there in the results. So we can chop it off. We also proved the combination therapy was superior. So here, if we still have words left, maybe we can say, we can put them here, right? Versus HCQ monotherapy. There we go. So how many words are we now? 202 down from 363. Right. Dr. Suma, any further inputs?
I think the title again needs to be changed.
Right. So we can move to the title according to you. Just give me a sec. I had done this practice run before the session today, and let me just check if we've got all the changes. Yes, we in fact ended up doing some extra changes, but looks like we included everything. So now again, the title, DMR therapy is effective in chikungunya arthritis. What do you think about it?
I would say efficacy of DMR therapy in chikungunya arthritis, a randomized controlled trial.
So I invite the house now to give their inputs. You can please feel free to unmute yourselves and tell us how you would like the title to be. Anyone out here on Zoom wants to join us in redrafting the title? So first of all, this need not be in capitals.
Yes.
And there need not be an exclamation mark. Even if it's the best study in the world, there need not be an exclamation mark. So efficacy of DMR, of combination DMR therapy. So efficacy, it's saying it's effective. So you can say efficacy of, or, so I would say the most important part is to say that it is a randomized control trial. So ideally the title should reflect what kind of a study it is. So randomized control study trial demonstrates that combination DMR therapy is superior to monotherapy for chronic chikungunya arthritis, right? So that is very important. So let's see at what title I drafted earlier. A randomized controlled trial of combination DMR versus monotherapy in chronic chikungunya. So this is the most common question we get, that can you give away the results of a study in the title? I guess you can. Sometimes it's your study. It depends on how you want to do it. And if you think the title is not enticing enough, it's dead. You know, someone is really bored and they're like, oh, it's just another randomized controlled trial. Then maybe you want to give away the results, because anyways, they'll still want to see what was the patient population like. So you could do it either ways, but ideally the title length should not be too long. This is slightly going over the word limit 16, but it should be okay under 20. Ideally it would be 12. So I'd like this one better. Randomized controlled trial of combination DMR versus monotherapy in chronic chikungunya arthritis. And you can say CS-DMR, compound synthetic combination synthetics, DMR. You need to specify what DMR. And then we go to the important part, that is keywords, which is often ignored even by me in all my manuscripts. And I had to actually go over it today to teach all of you. So anyone with any inputs about the keywords?
I had something about the title.
Yeah.
I mean, I can tell that later. But
no, let's go over the title. Please give your inputs, Dr.
Yeah. So how many of you think you should be using efficacy here, and how many think you should be using effectiveness? Is there a difference? Any suggestions?
Efficacy means it's basically you're not announcing the result. And effective means you're stating the result in the title.
Anybody else? Any other ideas?
Yeah, as a pharmacological, hello?
Yeah. Please.
As pharmacological point of view, efficacy means how the that is how actively how much actively the drug is acting. That is actually some definition of efficacy, the distinct definition of efficacy, which can compare the drugs according to their effectiveness. So I think efficacy is, as we are comparing the drugs here, efficacy is more useful term.
Any other inputs?
The efficacy is from the point of the drug combination or the drug per se. Effectiveness is in the point of what is the response the patient has in the patient's perspective. As far as chronic chikungunya arthritis, the outcomes are concerned. So yeah, efficacy, I would prefer effectiveness to efficacy.
Okay, any other inputs? Okay, fine. I'll just give my viewpoint here. What happens in efficacy is you are looking at the effect of the drug versus the comparator in controlled conditions. So as far as I could understand, this was an open label study. Although it was a randomized controlled study, it was open label and very much in keeping with, there was not much of blinding. It was very much like a clinical practice setting. So here effectiveness would be actually a better word. Whereas if it were a double-blind, placebo-controlled study with very rigorous visits every 2 weeks, something which is not really real life, or you cannot replicate it in real life, that is where you should use efficacy. Here, I think effectiveness would be a better word. And you use either, it doesn't say that it's effective or not effective. It's just to do with how much it mimics real life. So open label studies, preferably you should be using effectiveness. Observational data, you should be using effectiveness rather than efficacy. Efficacy is, as somebody I think pointed out, is what is done in an ideal population, in an ideal setting, maybe with follow-up intervals and trial settings, which may not be real life, which may not be able to possibly replicate in real life.
Right. Thank you, Dr. Durga. Now we move on to the keywords. That is the last part of today's session. So that is viral arthritis, methotrexate, epidemic, musculoskeletal. Dr. Suma, what do you think about those?
See, the one thing is the keywords is something that's going to improve our citation, thing at the end of, after we've done a publication. So we do have to be careful in how we choose them. It's not something that I've concentrated upon, but it is actually really important to think about them in advance. So here, chikungunya is not present at all in the list of keywords given, and that is primarily, where we have done this research. So chikungunya arthritis, then combination DMARD therapy, rather than just methotrexate, it should be there. Then chronic, persistent, possibly that needs to feature as well, because this thing. And what else? It could be a
Right.
range of things that you could give.
So how, if you were working on something which you're not so familiar with, how would you know that these keywords are right? Okay, we have a list here, but
yeah, the mesh guidelines.
Right. So mesh is basically, mesh network is medical subject headings. And these are the key terms which help. And if you use the right terms, then they'll come up in your database in the PubMed and Medline. It'll come up when searched with those terminologies. And researchers who are familiar with these terms will use the right terms while searching, especially if it's a systematic review or someone is conducting a narrative review or case-based review. You really want your article to feature there. And it should not be just because you were too tired at the end of the manuscript to drop the right key terms, which often is the case. So today, to teach you, I went over this mesh terms and what are the various ways in which we can get to it. And I'd say the simple solution is mesh on demand, my recommendation for today. And it's very easy for people like me who don't like to do it the harder way. So you just put the title there and you search. So it will itself suggest the key terms. That is the simplest way of generating key terms, because however hard you try, you may be wrong sometimes and you may not be totally accurate. So see, anti-rheumatic agents, you see, it's agents, it's not drugs. You know, there's no dash between anti and rheumatic. So if you were to put in the key terms, you were likely to be wrong. Chikungunya fever, we would have never written that, you know, arthritis rheumatoid, because rheumatoid-like manifestation is what chronic chikungunya is all about. Combined modality therapy, we would have never got at this, you know. And then here is our abstract. Another easy way, if we don't come up with enough keywords by this strategy, the mesh on demand also allows you to put in the abstract and search. And typically, because it's a large body abstract, there'll be more words scanned and there'll be more options coming up, which you can very conveniently choose or choose to keep or reject from your final keywords. And depending on the journal specifications, the number of keywords allowed can differ. My internet is slightly slow today, but yes, this is the preliminary search I conducted earlier. And the terms that came up was humans. Okay, we don't want humans, but hydroxychloroquine, methotrexate, sulfasalazine, chikungunya fever, combined modality therapy, prednisolone, and pain. Yes. So some of these can definitely be picked up. This is the easy strategy, and that is my 2 cents for today. With that, we come to the end of the session, and thank you all for joining us, and invite questions related to the manuscript or anything else. So there was a question related to the rubric regarding the scoring system.
Yeah, I think Latika, you just send them the rubric system.
Right.
There are couple of things about the this thing. I just wanted to. I think, you know, the keywords. Suma said very well. So all the words in your title and everything you put in the keywords are actually keywords. So if you were to increase your sort of, you know, you can say the scope you have in terms of offering more keywords, what you have put in the title should not be there in the keywords. So different. So if I have put DMARDs in the title, then I should be using methotrexate. So whenever somebody searches for methotrexate, you know, that would come up. If I have put chikungunya there, then of course arbovirus or viral would be a better choice in terms of keywords. That was one. And the other thing I just wanted to say was so I don't want anybody to have any confusion, but I think, you know, it was brilliant to be brutalized in this way, the manuscript, I mean. So what is important is, I just want to, so see, we have among us, the number of people attended this workshop had variable sort of expertise and experience in publishing, editing, and reviewing. It is important that whenever we write a manuscript, we use what is called a local peer review. Okay, let's say, for example, if Suma has written a manuscript, she can send it to Latika, to give her comments. So this type of, an unofficial, informal type of review will actually help in picking up a lot of mistakes. So whenever this particular sort of, dummy paper comes up for discussion in the workshops, we show the actual published version, which I have posted in the, and Latika had posted earlier in the email also. It is there, and you can see that, almost all the points which came up for discussion today, they have been incorporated in this study, which was published about 4 years ago. But still there are some mistakes. And I always say that had I used, local peer review, had I sent it to, say, Latika, Durga, Molly, or Suma, I would have actually probably, this would have come out much better. So I would like to sort of, thank all of you for making me relearn this process. Thank you.
Yes, thank you all for joining us today. Thank you, Dr. Suma. And we'll close the session for today because we're running late. Maybe we can take some of the questions next time. Good night and take care.